All right, ladies and gentlemen, we're about to begin our session. If you haven't yet grabbed a coffee and a muffin at the coffee station, I'd just like you to please go and make your way there and then come back so we can officially begin the session. And without taking up too much time, good day, ladies and gentlemen. My name is Refilwe Zim from the Frick Scott Library. Welcome to our millionth coffee talk. It's so good to have all of you once again. We haven't had a coffee talk in quite a while. And it's so good to see you. Today we are, okay, actually let me not tell you why we're here today. Who knows why we're here today by a show of hands? It looks like quite a good number. All right, so today we're speaking about the safe prescribing of medication. And I am joined by Prof. Paulina van Zyl from the Pharmacology Department, as well as Mr. Zelda Lewis from the University's Hospital Pharmaceutical Services. And I just would like us to go through a few house rules before we officially begin. The first being, please have your phones on silent so that we don't disturb the media team that's working. Secondly, due to the POPIA Act, I need to inform you that we will be taking pictures during the session. So if you do have a problem with that, you're at the wrong place. And then lastly but not least, the ladies' restrooms is just behind this banner. There's a small passage. I am not quite sure where the men's bathroom is, to be honest. Downstairs. Okay, thank you so much. You see, it helps to know people who know things. All right, and we're going to begin now. And as we begin, I'd firstly like to say thank you so much to our guests for joining us. You can see these two lovely ladies made time, obviously, today. We're going to engage with them. Please feel comfortable. Please feel free. At the end of the session, I'm going to open the floor so that you can ask any questions that you might have. Are we all on the same boat? Yes. Okay, all right. Thank you so much. Ladies, welcome. Thank you so much for coming. I'm very excited about this conversation because I think many of us have either been given medication by a doctor, gotten medication over the counter, and I know there are many people here with lots of questions. But the first question would be, what is meant, Prof. Paulina, by safe prescribing of medication? Why does it matter so much?
I'm so glad I can tell you what safe prescribing is, because I think the first thing is you think that is just ordinary words. Now, pharmacology is full of sort of landmine words that mean something different. So in the context of pharmacology, safe prescribing refers to a specific approach to prescribing. And it became necessary because we doctors are humans. We make mistakes, and these mistakes may reach our patients. So it became necessary to have an approach to how are we going to improve our prescribing so that our patients doesn't suffer harm from the treatment. So it's an extremely important concept. The prescribing function of a doctor is at the center of that doctor's functioning. And the prescription becomes a mirror of how that doctor operates. So you can see why it is such an important issue. Now, safe prescribing is not the only approach to improving prescribing. There's also other movements such as good prescribing. It's another landmine word. You think you know what it means, but it is a specific concept that needs to be unpacked. Now, for the safe prescribing specifically highlights the actions that we need to take. And there's 5 things here. 5 things. The first is the assessment of the patient. The second is to consider your evidence-based treatment options. The third is to involve your patient in the decision-making about treatment options. And the fourth is writing the prescription. So it's not just straight into writing the prescription, it's about the planning, doing the prescription, and eventually checking and monitoring the outcome of that prescription. And especially if you've got chronic medication, to go back and see, is it really still necessary for this patient to be on this medication? It's not that in every case you need to be on this medication for lifelong. I hope that answers the question.
It definitely does answer the question, and you can also hear the seriousness of it. Now, Prof. Paulina, once again, I'd like to ask, in terms of clinical judgment, what factors are considered before initiating new medication for a patient?
Okay, so I want to structure it into 3 points. I can't remember more than 3 points. I'm glad that I remembered 5, but 3. So first, it's about knowing your patient. Now, you need to know who is sitting in front of you. Is this a teacher? Is this a doctor? Is this a farmer? Because it might have an influence on whatever he's going to tell you. So you need to know who the patient is. What is the presenting symptoms? How did it come about that he's complaining of whatever he's complaining? You need to have a good understanding of what is his medical history, what happened previously in this person. Is this the first time, or has he come along with this thing? You need to have a very good understanding of what medication he is already on. So the medication history is extremely important, because there we need to now fit in our new treatment plan, or we need to change things so that it works for the best of the patient. So that's the first thing, know the patient. Included in that would be things like, does the patient have allergies? Does he have hobbies that expose him to certain environmental factors? So all those we can clump together in knowing your patient. Then secondly, you go for information that supports the diagnostic reasoning. So you want to know what happened in this course of events. How did he play out? What happened first, and then what happened next? So you want that scenario to be painted so that you can arrive at a diagnosis. And obviously, also into that information, you incorporate the findings of your physical examination so that you arrive at a diagnosis. So the second part is about diagnostic reasoning, and it culminates in a diagnosis. The third part is collecting information to support therapeutic reasoning. So your therapeutic reasoning is about what medication are you going to select. And you do that taking into consideration the patient's information that he gives to you, but also you need some information from the outside. So you need to know what kind of medications are available. What are my available options? What is allowed according to the specific formulary? What is available in the pharmacy even? So that kind of knowledge is plowed into your therapeutic reasoning. So the therapeutic reasoning culminates in a therapy plan. And that plan can be medication, but it might also be non-pharmacological interventions. So you get the picture, 3 points. Identify or know the patient, get together the information that supports your diagnostic reasoning, and then get together the information that supports your therapeutic reasoning, so that in the end, you can justify, I picked this medication because of this process. This medication that I chose is evidence-based, so I've consulted my formulary, it's evidence-based, and it fits into this patient's current situation.
You mentioned knowing the patient's history. What happens then if, let's say, this patient is not a patient who regularly goes to the doctor, doesn't have a file, like there is no medical professional who has the history of the patient, and they decide in their, in their older years, okay, they want to start taking their health seriously for whatever reason, and they go and they need to get over-the-counter medication. What then would be asked of the patient in that scenario?
Okay, I think maybe I should ask Zelda, because she's the pharmacist, and maybe she can allow to us what happens between the patient and the pharmacist when they buy over-the-counter products. Yes.
Thank you very much. What we usually do when we counsel the patient on the use of medication or even over-the-counter medication is that they need to be informed that there can be drug-drug interactions with some of the medication. And usually we ask, but on what medication are you? Just to make absolutely sure that there's no interaction, or to advise the patient when you issue medication according to a prescription, do not take any other herbal medication. Even drug-food interactions can play a role when patients taking medication. So we would usually advise the patient to have a list of all the medication that they are on and inform the doctor or other healthcare workers so that we can inform them correctly on the use of medication, or refer them back to the doctor or inform the doctor, with interventions. Thank you.
We're still on you, Mrs. Zelda. I also would like to know, what's the role of the pharmacist in preventing prescription errors from reaching the patient?
Okay. When we receive a prescription, there's quite a lot of compliance check that we do. Firstly, you do an in-depth evaluation of the prescription, look at drug-drug interactions, whatsoever. You look at the patient history. Then you capture the prescription, you double check yourself that the labeling is correct. Then there's staff members within the pharmacy that check the medication. A pharmacist would then double check and sign off the picking process, I can almost say, done by pharmacist interns and pharmacist assistants to ensure that it's for the correct patient, correct dose, the right route of administration, and then it goes out with counseling. And again, with counseling, you counsel the patient why they are using it, how to use the medication before meals, after meals, what kind of side effects they can expect. And that's also where you ask the patient on what other medications you are. Then also allow the patient to ask questions back regarding the medication, so that you are absolutely sure the patient understands for what they are using it and how to use that. I think that's that.
And then also in terms of the wording, I know a lot of people get a bit freaked out because medicine has its own jargon. Do you explain to them in a way that they can understand, fully understand? Because you must remember, in the country that we live in also, the gap between rich and poor is pretty large. Yeah.
Okay. If a patient, you pick up that there's a problem that they don't understand it due to language barrier whatsoever, we make use of an interpreter. Where you stand next to the interpreter and explain that, say for instance, in Sesotho. Or sometimes what we do, we make use of pictograms. in explaining the patient, okay, early in the mornings, middays, we've got certain pictograms that we use in explaining the patient, even making round circles. You take 2 tablets, for the patient to be absolutely sure that they know how to take their medication.
You're going to think that I'm on your case because I'm asking you quite a lot of questions now. But I think it is important, especially as a pharmacist, because at the end of the day, as the patients, we interact more with you. I'd also like to know, what can prescribers do to prevent prescription errors? Or maybe both of you can take this.
Prof. Paulina?
Okay, well. Hello. Sorry, this one is dead. Hello. I think this is the beauty of safe prescribing, that it gives you a method that you can actually apply. I think it's about developing good prescribing habits, safe prescribing habits. And if I can simplify what's been going on, like I said, I will go to 3 things. The first thing is plan. Plan, 3 plans. Now, the planning is about the assessment of the patient, the treatment options that I have, and getting the patient's consent and consensus with the patient, getting that into the planning phase, and then into doing. And when you do, you write the prescription, you have to bear in mind everything that needs to be on that prescription, because it is a legal document and there's legal requirements for what must be on that prescription. And then finally, check and reflect. So checking on what you've done now, checking for drug interactions, alerting the patient to possible side effects, and also referring to the longer-term process where you monitor the patient's progress, and if there's adverse effects to report that as well. So I think it's about establishing a habit of safe prescribing.
Yes, I think there's 10 principles for good prescribing that's in the British Pharmacological Society. And I think most of the things Prof. Paulina already touched on, that you need to be robust identification of a patient to make sure that this is the patient sitting in front of you and that the patient is correct. The reasoning for prescribing, you need to be clear regarding that with a medication history. And then also other factors where you weigh the benefits and the risks. Then also sometimes the patients come and they've got an idea and request the doctors to prescribe medication, and that's not within their clinical area of knowledge. And the rewriting of prescriptions can also cause medication errors. Then also to know, what is available. I like, and we prefer that it's written in the generic names, because especially in the Department of Health, we work on contracts and the trade names are different. Not to use abbreviations, because that can also lead to confusion. My interpretation of an abbreviation can be different. Communicate with the patient. I think communication with the patient is also of utmost importance, because if you rush something off, it can also lead to errors. Yes, and that's from my side. Thank you.
Thank you so much, Mrs. Lewis. I just wanted to know also, errors are natural and it does happen, but are there any serious legal implications that can take place if a patient is given the wrong medication?
Yes, it's not just the wrong medication. It might be a mistake in calculating the dose, for instance, or it might be an inappropriate medication for a child, for instance, or a pregnant patient. So it might be inappropriate for that particular patient. So there's a lot of things that can go wrong here. So from a legal point of view, obviously it depends on the amount of harm that comes to the patient. And if it can be proven that that harm is related to what you've prescribed, and that then definitely they can lay a case of malpractice, medical malpractice. And there are legal firms that specialize in taking medical practitioners to court on that. So yes, there's legal implications, but there's also other professional implications. So for instance, they can lay a complaint against you at the HPCSA, and that may result in disciplinary action. So it depends on the specifics of the case. But locally in the system where you're working, you must also bear in mind that if you've got poor prescribing habits, you are actually creating risk, not only for yourself, but also for the pharmacist. Because in a way, having the pharmacist having to check your, they support you, and it's like a safety net if they check your prescription. But say, for instance, they miss your mistake. That pharmacist also is in the line of getting problems. So it's about not creating risk for yourself, but also for the people who work with you in the team.
Yes, medication error for the pharmacy will always stay a risk. And even with errors that happen, in-depth investigation or root cause analysis will be done, where even systems are teared apart to ensure that systems were in place to ensure that you don't miss medication errors. And even as a responsible pharmacist, I can be held accountable for errors somebody made within my department. So that's why it's so important to make absolutely sure, even with interventions that you do on a prescription, that you record it, because if it's not recorded, it's not been done. Because sometimes you phone a clinician and the clinician insists on using the dose, even on the recommendation of a pharmacist for specific reasons. That's why it's so important to record all interventions done on a prescription, that you can cover yourself. A pharmacist may also, if you look on the system and you see the patient received something previously, it's the responsibility of that pharmacist to phone the doctor and make sure there was a change in the regime or prescribing of a specific medication. But yeah, it will always stay a risk within the pharmacy.
So all the information needs to be as correct as possible.
Perhaps I can just say regarding all, it is a legal document, and what needs to appear according to the Pharmacy Act and the Medicine-Related Substance Act, the following information need to appear on a prescription, the details of the patient. And with that we say initials, full initials, surnames, the address of the patient, the age of the patient, the date of the prescription is very important, the drug name, the drug route of administration is very important, the drug strength, the dosage form, the time frame, the direction for use, and then also very important, the number of repeats. And usually a prescription cannot be repeated more than 6 times. And then also the doctor's information, his registration, so that can also be checked if this person have the permission to prescribe that. So all that information is of utmost importance, and then also to write it on the correct documentation as prescribed, say for instance for Universitas Hospital. Yeah, I think that's what needs to be on a prescription.
I just want to emphasize one important point. Sometimes doctors will have somebody else write their prescriptions. People write horrifically. Doctors are known for, writing in hieroglyphics, and pharmacists can actually decipher hieroglyphics. But of course that creates a massive risk. So it is a legal requirement that prescriptions must be legible. It's a legal requirement. And so sometimes doctors will, to make sure that they comply with that, they will have somebody else write the prescription. But what makes it that doctor's prescription and therefore his responsibility is the signature. So the 5th-year student or the 6th-year student might write the prescription, but you sign on the dotted line as the authorized prescriber, and it means I have checked this and I take responsibility for whatever is written here. So that's very important. That's an authorized prescriber that must sign the prescription, and the authorized prescriber is the responsible person.
Sure, it sounds hectic. One last question. Oh, this sounds very hectic, and it sounds very serious because, all of us at some point, we've had medication prescribed to us, but what is the patient's responsibility in all of this? Is there any at all?
Definitely, the patient's got a responsibility. They need to be aware for what the medication is and for what they are using that. To take it according to instruction, be compliant with the medication that's being prescribed, otherwise it would be, they come back in a worse state to the doctor, and then the doctor don't understand the reasoning because he prescribed the medication. To report side effects, because sometimes patients leave medication due to side effects. To also tell them not to stop their medication without consulting with a healthcare professional, a clinician or a pharmacist, before they stop their medication. Also, not to share their medication. It's individually prescribed, especially in elderly homes. This is my tablet for my heart. Do you want it? Or I'm not feeling well today. But really the patient's got the responsibility, and one other responsibility is to make sure that they safe keep the medication, so that children can't reach it, that it's stored correctly, because otherwise you get degrading of medication. So yes, it's a chain reaction. Start with the clinician, pharmacist, the person doing the administration, if it's the patient or the nursing staff. So it's a multidisciplinary responsibility. But yes, the patient do have a responsibility.
It sounds like everyone has a role to play. All right, I'm going to open the floor now to take a few questions. I hope you're ready. It can go anyway. I'm just gonna ask that this mic, the mic that I'm holding, can just rotate, please.
Prof. Paulina, I just quickly want to ask, normally you must sign your prescription in your own handwriting. Is it now legal to sign it with computer-generated signatures or not?
Remember, with computer-generated signatures, there's two types. There's the one that you can copy and paste. That's not acceptable, but the digital signature is acceptable because that gives a specific date, and it is supported by certification that it is your signature.
Yes, right here in the center.
Thanks so much for explaining everything to us so well. I was thinking something that happens quite a lot is what's called off-label prescribing. Does that fit into the model of safe prescribing, or how would you explain off-label prescribing to those of us who aren't pharmacists or pharmacologists?
Okay, so off-label prescribing is where a drug is not registered for that particular indication or for in that particular patient group. So what it means is that the manufacturer does not take any responsibility for the use outside what it is registered for. So you're taking on a big load when you prescribe off-label. So number one, legally, we are not allowed to promote off-label prescribing, but we know that in certain circumstances, it cannot be avoided. For instance, in certain populations, like in small children, there are not clinical studies for that drug that was done in small children, for instance, but you now need to extrapolate from adult medication. So in a situation like that, make very sure that you've got literature backing for your decision, else you're standing alone. There's nobody behind you.
Just from my side, if you want to do off-label use and you want to be safe, you need to apply through SAPRA for Section 21 permit to say that you've got the permission to use it off-label. And that's usually a whole process that you need to go through. And then you get the permit and the pharmacy can import it, the specific medication. But as Prof. Paulina van Zyl said, it's not something that we promoted. But there are indications like the use of colistin for multi-drug resistance. It's not a drug available on the South African market, so we imported it. But that's also very important. There's procedures to follow and guidelines, like you need to get an informed consent of the patient. You need to submit progress reports regarding that. Thank you.
2 more questions and we're closing the session. All right, I see a hand over here. I see another hand over there. Let's start with the one on that side. There are 3. Okay, 3 last questions.
Good day, profs. My question is based on drug, traditional medicines, interaction, risks in patients. I would like to know whether you've encountered such scenarios in patients, and if so, I would like to know, are there any models that address such drug, traditional medicines interaction, and which models are you using in order to address these risks and issues from the patients and the traditional medicine prescriber?
Yes, I think the problem with traditional medicines and interactions, there are certain herbal medications that are well known to have drug interactions with conventional medicine. But remember, to be able to say that I am sure that this interaction occurs, you need some research to back it up. So if there isn't a specific research done on that, we really don't have the information. So the body of knowledge about interactions. Say, for instance, I take garlic. Now, so for many people, garlic is a form of traditional medicine. So, but it can also cause bleeding tendencies when taken together with anticoagulants. So that may be something that appears very soon and that we know about because it's widely used, and so it may become apparent very quickly. But there's other things that are not used on a wide scale and that people may be unaware of. So yes, it does. There are interactions, but remember, it is also something you have to have the specific drug and you have to have the specific herb to decide whether there is a interaction. And in many traditional medicines, we don't know the pharmacology of that particular product, so it's very difficult to predict.
Second last question.
I just want to ask, in terms of legibility and also just abbreviations, I know a lot of doctors like to use terms like TDS in terms of frequency. They like to use TDS, QID, BD. And I've been in environments where it's stressed, there's no, you must write out 12 hourly, 8 hourly, 6 hourly. I just wanted to ask, as a pharmacist, what's your feeling on that?
Okay, there's a list of abbreviation, Latin abbreviations that can be used, TDS, BD, Q6 hourly. Regarding legal prescriptions, we talk of abbreviations with medicine names. The doctor would write MPH for methylphenidate, which is not a known abbreviation, or ASA for aspirin, which is also not a known abbreviation, and it can be interpreted by different people in different ways. We are currently addressing and we took it up with National Department of Health, the use of abbreviations with ARVs and TB, because in many of these ARV and TB guidelines, they use abbreviations. But according to the Act, abbreviations cannot be used. So currently we are waiting for feedback from National Department of Health. That's not yet been concluded, but the risk for medication errors is very high if you use abbreviations.
Our last question. Oh, yes.
I just want to add something on abbreviations. Everybody's got their pet hate now. My pet hate is PRN. PRN is never at the end of a sentence. It should be PRN for nausea or PRN for pain. No? It can never be at the end of a sentence. So that's the one thing. The other thing is you mentioned TDS. I remember there's a difference between if you say 3 times a day and if you say 8 hourly. It's not the same thing. If it's 8 hourly, it means you have to sit with that stopwatch and 8 hours you can take the medication. If it's 3 times a day, it may be morning, noon, and before bedtime. So that's also 3 times a day. Thank you.
Good day, everyone. I almost forgot my questions, but within the pharmaceutical perspective, is there any strategies or policies that are there in place to prevent or mitigate the abuse of prescription drugs? For an example, if a patient consults this medical practitioner and then now they can no longer get the drug, and then they go to another medical practitioner for the same drug, and within medical practice, how do you then mitigate a situation whereby a patient says that, for an example, a morphine-dependent patient says that, I want morphine, and I don't want anything else other than morphine. Are there any strategies in place to mitigate such situations? Thank you.
It is things that we've picked up previously, and I think what is very important, never to pre-sign prescription charts, because that we've also picked up previously. Yes, the pharmacy is the gatekeeping. So usually regarding records and history, we've got a stock management system and a history of the patient as they receive medication, especially with higher scheduled medication. Remember, you may not issue that within a certain time frame. We keep register with the highly scheduled substances. And when we pick up, but this patient is now earlier year, we consult with the doctor and we have that discussion with the patient that we cannot. So yes, there is systems in place to try and prevent that. Also, when you pick up that this patient is doing pharmacy hopping or doctor's hopping, you know, there's systems in place in reporting it to the pharmacy council and to SAPRA, and then they will circulate a notice with the patient details to do that. But I must say we've picked it up previously with clinicians that will prescribe medication for themselves on a patient's prescription and come and collect it. Or you will have pharmacists misusing scheduled substances. So in the pharmacy, we've got systems in place to make absolutely sure. The law actually say you need to balance your registers every 3 months. We do it weekly. So that if you pick up an error, you are hands-on to immediately address that. Thank you.
Oh, there's a burning hand. This is the last one.
I just wanted to ask, is there a way that people could be more open about mistakes so that other people don't make the same mistakes? Because it feels to me like the whole system is kind of, okay, it's a legal document and you're going to be punished and you're going to be struck off the register and you're going to be in court. And all these things feel to me, there's so much fear that people kind of want to just brush their mistakes under the carpet. And wouldn't it be much better if people can just say, you know, just look out for this mistake and that mistake, because, you know, if they can kind of be like a register or a registry of common mistakes made that can be avoided. I know when I was a student, I used to say, always write units for the insulin, because some people they used to put IU and then the I would be interpreted as another part of the number, and then the person would get kind of 1,000 times more or 10 times more than they're supposed to get. But yes, I don't know, is there kind of like a register that one can go to online that tells you the most common mistakes and how to avoid it?
I'm not aware of a system like that, but I must say in the preparation for this, Zelda actually made a list of common mistakes that they encounter in the pharmacy. So it might be, obviously one will have to be very careful not to make it, you know, people feel that they are exposed or that there's damage to their reputation. I think one should be very careful of that. But I think it might be good to get a system going where we give feedback to a broader audience. They try to contact the doctor who's made the mistake, and they give feedback to that doctor, but maybe one can bulletin.
And you can't distinguish who made the mistake, but just like so that everyone can see, oh, these are the common mistakes that happen.
in South Africa or worldwide, and that is not necessarily a place and a person that's pointed to.
Yeah, especially with medication, or not just with medication error, but errors on prescription. As Prof. Paulina said, we firstly contact the clinician, speak to them and say, you know, we picked up this, say for instance, the details of the patients is not, you know, on the prescription, and it's the clinician's responsibility to do that. The comments sometimes would be, but there were not labels, but it's still your responsibility to write that. It may be an omission that they forgot to write the date. It's a human error. Regarding dosage with children, or, you know, that can be an error, and yes, it's a near miss if the pharmacy pick it up, but it should also be reported in a safe environment. I think where it becomes serious regarding errors, if the patient took the medication and it was to the detriment of the patient, then we are forced to enforce disciplinary action, because that's one of the first things that they ask you if you go to court. But what have you done to address that? What systems have you put in place? But I think it's a good idea, perhaps like a clinical bulletin from time to time, just to say, make sure these are the errors that we've picked up.
Like prescribers anonymous, almost like Alcoholics Anonymous.
Yeah, yeah.
I just said it's like prescribers anonymous, almost like Alcoholics Anonymous, and then you can learn from each other's mistakes.
I can see she's the creative mind is working here. I think that one important thing that I would like to make in conclusion is that a good prescriber checks himself, and it's good to check dosing, and especially dosing for children and elderly people, pregnant patients. Check those. Everybody doesn't know everything. It's good if you've got a book, you need to check. A doctor needs a book because you don't know everything. So checking is extremely important in safeguarding. For instance, with children, never ever assume, okay, this child is about half an adult, I'll give him half the dose. Now, it cannot work like that. It cannot work like that because it is not as simple. We think of growing up as a linear process, or growing old is also a linear process. It feels like it, but it isn't. There's so many changes that occur, and processes that mature at different speeds, that for one medication there may be a specific instruction for a baby, another dose instruction for a child of 5 years old, and another dose instruction of a child of 12 years. So especially in those patients who are so vulnerable for errors. It's your children and babies, your elderly patients, patients with renal or liver or heart failure or some organ impairment, and also pregnancy and lactation. Check. That's the bottom line. Check. Thank you.
Sure, this is a very important conversation, and the more you speak, the more that is highlighted. But in closing now the session, I just want to say from the library, we just have nice goodies for you. This is for you, Prof. And this is for you, Mrs. Zelda. We just want just a small token of appreciation to say thank you so much for your time, and also just contributing towards this conversation, because I don't think any of us, well, at least most of us, weren't aware of everything that's going on in terms of safe prescribing and medication. Thank you so, so much. And to our audience, thank you so, so much. You know, you make this coffee talk possible month in, month out by inviting your friends and, you know, all your other acquaintances, spreading the word on social media. I'd like to encourage you to continue with that and also just being here. Thank you so, so much. We have our last coffee talk coming. If you don't follow us on our Facebook page, it is UFS Library and Information Services on Facebook. On Instagram, we are UFS_library. That's where we send out all the information about the coffee talks as well as the digest. So if you want to come to the next coffee talk, sometimes I even send some people reminders because I know they're very forgetful. They know themselves. They're somewhere here in the audience. But thank you so, so much for coming. Please give yourselves a round of applause for being here. Thank you so, so much. And lastly but not least, please give our speakers a round of applause for being here too. With that being said, thank you so much for your time, everyone. Continue having this conversation. It shouldn't just end here in these corridors. Go out to your families. Tell them what was said today. Tag us on social media if you are on social media, if you enjoyed the session. We really love, you know, engaging with our speakers. And if you yourselves know people or the conversations that you'd like us to have, please come and knock on our doors at the library and let us know. Let us know. Thank you so much. We'll see you again. Thank you.